All right, we've got some folks commenting in the chat. Thanks so much for joining us. My name is Dan Parish. I'm the Vice President for College Advancement at Colby-Sawyer College. I really appreciate you joining us today. We have a great program planned for you today with two public health experts who both have close ties to Colby-Sawyer College. And right now we have an audience of just about 90 people with us, and that will grow a little bit in the next few minutes as folks join us. Again, a few technical notes before I introduce our panelists. A number of you submitted questions in advance of today's conversation, and the panelists will address as many of those questions as they can during their presentation. And then I'll keep track of the questions as we go along and add additional follow-ups after they finish. The panelists will make a presentation and then we'll open it up to the Q&A after that. If you've never been part of a Zoom webinar, you've realized by now that you can connect with others through the chat, but you cannot talk at us verbally. So if you need to share anything with us or you have questions, please let us know. You're welcome to submit those via chat. You can also use the chat to let us know if you're having any problems hearing us, and we'll try to make adjustments. What we can't do, of course, is help with any technical problems you're having with the audio settings on your computer. So all we can do there is wish you the best of luck with that. We will share a recording of today's session after this session by email. We'll try to get that out in the next couple of days, but it may be early next week. But we will email everyone who participated today with a link to that video, and you're welcome to share that as well. We are very fortunate to have two experts who joined us here today to help us better understand the coronavirus pandemic and to answer our questions. Anne and Paul will lead us through a presentation for the first part of the webinar, and then we will turn to questions. Let me provide a short introduction of our panelists, and then I'll turn it over to them. Anne Sosin teaches public health at Colby-Sawyer College and serves as the program director of the Center for Global Health Equity at Dartmouth College. Anne has years of experience leading global health and international development partnerships at the local, national, and international level. She just recently published an online opinion piece in Stat News about what the US can learn from low-income countries about preparing for a pandemic. Paul Etkind is a study leader in the Adventures in Learning program at Colby-Sawyer College and a retired public health epidemiologist whose work concentrates primarily on infectious diseases. He has worked at the local, state, and national levels as a public health program and division director. Paul is widely published and continues to be active in professional organizations throughout the US. We're grateful to Anne and Paul for leading this important discussion, and I am going to hand it off to Paul to begin. Thanks so much.
Okay, good morning or good afternoon, everybody, and thank you for spending some time with us. We share your sense of importance for this. I want to talk about, initially, just talk about the big picture of emerging infections or infectious diseases. This was a trend that began to be noticed in the 1950s. National Academy of Medicine produced its first major report on this in, I think, 1992. Question, why are they emerging? We live in a very connected world. Modern demographics, modern technologies, business conditions, scientific advances, policies, environmental conditions, and political considerations are all interconnected in ways that sometimes we can predict and sometimes we can't predict. So if we want to just go through briefly, global travel, we have close to about 2 billion people, that's billion with a B, crossing international borders each year at this time. Population growth, it took 200 years for the population of this world to double between 1750 and 1950. It went from approximately 1 billion to 2 billion people. It tripled to 6 billion people in the next 50 years. And we're seeing an increase in urbanization, with cities of 20 to 30 million people not being all that unusual now. For population movement, we have people moving across borders because of war, famine, drought, and disasters. In 1975, it was estimated that about 2.7 million of 4.1 billion people were classified as refugees. In 2014, it was 14.4 million out of 7.1 billion population. It was a increase by threefold. Climate change. We're seeing, as one example, tropical diseases are becoming more common in temperate areas. Ecosystems are being completely disrupted. Human populations are expanding into what had been previously wilderness habitats, increasing the risk of exposure to previously unknown infectious disease agents. There's been a globalization of our food supply. It comes from a bewildering number of sources. We've seen destruction and alteration of habitats. There have been many changes in medical care practices as well as in policies. We've increased the use of antibiotics and pesticides, with a big result of that being increases in resistance to those tools. We're seeing behavioral changes, increased use of drugs, and increases in risky sex. We're seeing technical changes in healthcare as well as in food manufacturing, all of which have intended and unintended consequences. And finally, our political will changes depending upon the issue. Sometimes we will address problems, sometimes we'll deny them, and sometimes we just try to kick the can down the road. Anne, you want to take it from here?
Thank you, Paul, and hello everyone who's listening today. I want to just begin with an overview of where we are today. As of this morning, there were over 2 million confirmed cases of COVID-19 and over 138,000 deaths. And we know that the true numbers, both of cases and deaths, are significantly higher, and this is in some ways a reflection of the availability of testing globally. I just want to preface my comments by saying that these are the numbers that we have, and what I am sharing with you is the evidence that we have as of today, but both the data and the evidence continues to shift very quickly. I first started thinking about the COVID-19 pandemic really seriously when I was in Peru. About 2 months ago, I was on a global health trip to the Peruvian Amazon as part of a collaboration with Peru's National Telehealth Network. And I was out at a remote airport in the regional capital, and there was a sign warning the region of the dangers of coronavirus. And it really struck me at the time. This was one of the most remote places that I had visited in my career of almost 20 years in global health. And already the government was starting to think about what the need to protect the local community. And I think as we have a community conversation on this current pandemic, it's important to think about what our role is. And I think the public face of this pandemic has been our healthcare workers who are doing really heroic work. But a lot of what needs to happen will happen at a community level. So let's just go back about 16 weeks to the start of the current pandemic. In late December, physicians in Wuhan, China, noticed a cluster of cases of atypical pneumonia that didn't respond to traditional treatment. Now we know that these cases were caused by SARS-CoV-2 virus. COVID-19 is the illness that's caused by this virus, and it's characterized by dry cough and fever. As you know, many people who have it also experience diarrhea, myalgia, and in its more severe forms, COVID-19 causes acute respiratory distress syndrome and acute kidney injury. Most of the people who have COVID-19 have mild to moderate disease. About 80% of cases are mild to moderate. 13.8% of people with COVID-19 will experience severe disease, and about 6.1% of cases are critical. And critical cases are characterized by respiratory failure, septic shock, and multiple organ dysfunction or failure. Currently, the WHO estimates the case fatality rate or mortality at 3 to 4%, and this is highest in older patients and those with comorbidities. I need to say that this number is really a moving target, and it reflects on a couple of things. One, we don't really have a good sense of the number of people who are infected because testing is quite limited in a number of settings, and also there's quite a bit of variation in the standard of care that patients are accessing. In South Korea, mortality was about 0.5%, and in Italy, it was much higher because of the structure of the population. Currently, there's no treatment that's been proven effective for COVID-19, although there are several clinical trials underway with some promising treatments. Some of you have heard about remdesivir. It's a drug that was developed for the treatment of Ebola. There are trials underway, including here in New Hampshire. Chloroquine is an anti-malarial that has also shown some promise. And there are trials underway with the use of convalescent plasma from persons who've recovered from the disease. Currently, treatment is with supportive care, and I'm sure that you've heard a lot about the use of intensive mechanical ventilation. There are still many unknowns related to this disease. We don't know if it's possible for persons who've recovered to be reinfected. We also don't know about the long-term effects it may cause. And there are a lot of questions around pregnancy. We know that the disease course for pregnant women tends to be similar to non-pregnant persons. However, we don't know about the effects, particularly early in pregnancy. A lot of you have asked about the differences between COVID-19 and seasonal flu. We know that COVID-19 has a significantly higher mortality rate, upwards of 20% higher. And the other problem that we're seeing is that whereas flu is distributed across a longer period of time, we're seeing such a high surge in COVID-19 cases, and that has significant implications for the ability of our health system to respond. So let's just talk quickly about how COVID-19 spreads and what this means from a public health perspective. We know that transmission can occur by droplets. We know that it can happen through contaminated objects. And we also have increasing evidence showing that its spread is airborne. We have evidence of the presence of the virus in human feces, but we still don't know whether fecal-oral transmission is really possible. And understanding this will be especially important as we think about the spread in low and middle income settings where the access to water and sanitation is much more limited. Growth of the virus is happening exponentially. The basic reproduction number is something you may have heard about. It's 2 to 3. And what this means is that every person who is infected will on average infect 2 to 3 other people. And that means that in 10 generations, one case will lead to about 59,000 cases of disease. There's also a really important role of asymptomatic and pre-symptomatic transmission. An estimated 20 to 25% of cases may be asymptomatic. And so someone can be spreading the disease without knowing that they're infected. And we also know that pre-symptomatic transmission can occur between 48 to 72 hours before the onset of illness. We have a really, really limited toolkit to stop the spread. We know that a vaccine is 12 to 18 months away at best. And so what we're relying on right now are non-pharmaceutical interventions, or NPI. And really what this means is putting barriers between people or spreading people apart so that they don't infect one another. So what we're seeing right now is a picture of crowded ICUs across the country. This is often how we encounter COVID-19, but I want to take you back a little bit through the course of the illness and how we get here. So if we look at the course of the COVID-19 illness, we know that a person would be infected on, say, is day 0, and they may have an incubation period of up to 14 days. On average, this is about 5.4 days, but it may last 2 weeks. Someone can transmit between 2 to 3 days before the onset of illness. And we know that if someone is going to experience a severe or critical case, that it will take an average 9 to 12 days before they're hospitalized. We know that if someone's hospitalized, that there will be about a median time to death of about 7 days. And that if they're going to be placed on ventilation, they might be there for over 21 days. Now, this all adds up to over a month of time. And over that, and then there's a really big difference between where we need to intervene in terms of time and what we're seeing in terms of the effects. And so some of the public health activities that we need to undertake have to happen long before we're feeling the consequences of those interventions. We know that the rapid growth has had enormous consequences on health systems globally. China, the first country to experience the epidemic, was unable to meet the demand for care, and there was a disruption of routine healthcare delivery. The Italian health system was subsequently overwhelmed to the point that the Italian College of Anesthesia, Analgesia, Resuscitation, Intensive Care published guidelines on rationing of care to patients requiring intensive care. And there was a significant disruption of other health services there. Let's look at the US picture, what was projected and as well as where we're currently at today. So the CDC initially projected that in the absence of countermeasures, there could be up to 214 million cases with 1.7 million deaths. And the projections showed that we would have a need for 49 beds per 100,000 patients if we accounted for underlying illness in our population. Now, we have about 34.7 critical care beds per 100,000 adult population. So this means that we would have had a shortage in the absence of the measures that are currently in place. And those shortages were estimated to be about over 36,000 beds and 16,000 ICU beds. In addition to bed shortages, there are critical supply chain concerns, including the absence of sufficient personal protective equipment or the masks that you're seeing healthcare workers wear, as well as diagnostics or testing. And these numbers also don't account for other systems constraints. We are based in a rural region, and our health system has more limited capacity in some areas than others, and it also doesn't account for the broader impacts on healthcare delivery and access. We know that patients need more than treatment for COVID-19, and that those services for other conditions are likely to be disrupted. So let's talk a little bit about where we are now. In the last week, we were warned of a Pearl Harbor moment as the epidemic unfolding in New York City. There are lots of discussions underway about whether what providers would need to do in the absence of sufficient ventilators and treatment. We see field hospitals that have been erected across the country. In our region, including in our region. Now, a lot of you have heard about the epidemic curve and the differences between the capacity of our health system to address the number of cases. And here is just a picture of what was projected from New Hampshire just a couple of weeks ago. This shows you that in the absence of certain measures, we would have excess demand for health services. And this is where the calls have come in that we need to flatten the curve. And this simply means that we need to take a series of measures to slow down the rate of the epidemic to a level that our health system can accommodate. And flattening the curve means that we're going to lower transmission. We're not going to stop it entirely so that our health system can catch up. And we also in doing this, we hope that we will mitigate the impacts of the pandemic on the health system. At the same time, we're trying to buy time for the development of vaccines and therapeutics, as well as to put other measures in place. We need to have sufficient PPE or personal protective equipment for our healthcare workers. We need to have more testing. We really need to be ready to confront ongoing the cases that we're going to continue to see. The tools that we have to use are public health tools, and those include case finding, contact tracing, isolation and quarantine, and social distancing. And I know that many of these terms seemed foreign just weeks ago, and that you're all you're all familiar with these terms, and as well as you're implementing them in your own settings. And there are various strategies for flattening the curve, and they differ in terms of the degree of application of these tools. The first strategy that we are always looking to deploy is containment. This means that we stop the epidemic, and we know that we're beyond that at this point in time. Mitigation involves taking a series of measures to slow down transmission. And those measures include the closing of schools, instituting social distancing measures, as well as taking other steps. And suppression means that we take this even further and we institute home quarantine in addition to the closure of our academic institutions. And this gives you a sense of the ways in which the curve has looked for other countries. And the point I want to make in looking at this is that the measures that we take or the policy options that we exercise really do determine the shape of the epidemic. None of the other countries that had flatter curves have had access to better tools than we have in this setting. But the other thing that I want to stress is that we're looking at deaths here because deaths are really the best indicator that we have at this point of how we're doing with regard to the epidemic. Deaths are it's a trailing indicator because we know that we're not going to see deaths until about a month after we've instituted a set of public health interventions, but it really helps us to understand how we're doing. This gives us a sense of where we are for New Hampshire right now. We are past peak at this point based on the current projections, but that doesn't mean that our concerns have gone away. So I know that the real question that everyone has, though, is not how do we close, but really how are we going to open again? And their answer is, if we're looking at a population right now, we don't know what the problem is that we have, and we don't have the tools that we need to address, to reopen. So this is what the population looks like right now. And this is what we really need to get to. So first, we need to have widespread testing that will allow us to separate the population into 5 groups. Those 5 groups include infected, or people who are ill or have been infected with the virus. The second group is the presumed infected. Those are people who have symptoms that are consistent with COVID-19, but may be testing negative. We know that the testing is not perfect and that there are a number of cases that are not being picked up with the available diagnostics. Then we need to know who's exposed. We need to know who's recovered, and then also who is still susceptible. And we need to have in place a series of interventions targeting each of these groups. For those that are infected or presumed infected, we have to make sure that we've hardened our health system in order to provide the care that they need. We need to be able to isolate them, and then we need to trace the contacts. So anyone who has been exposed needs to understand that they've been exposed and take measures to quarantine themselves. But for those that are exposed, we need to be able to quarantine them. And sometimes this is going to mean establishing community facilities so that they can be away from families and others that they might infect. And for those that are recovered, we need to be able to tell them that they can return to normal activity and that we can engage them in the response in a variety of ways. And for those that are susceptible, we need to make sure that we're still protecting them, especially those that are medically vulnerable. And this is going to be our first target group when we have a vaccine. And we estimate that this is about 18 months away. So to summarize, there are various plans for reopening that are coming out right now, and some of you may be reading them. There are certain conditions that most of them say need to be in place in order for this to happen. The first is we need to see a sustained reduction in the number of cases. And this means that the cases need to be going down for more than 14 days, which is the incubation period that we're looking at. We need to have widespread testing, including serological testing. We need to ensure that our hospitals are able to treat cases without being in a crisis standard of care, meaning that they're not delivering care in tents or disrupting other services. We need to have public health surveillance in place, and we need the ability to protect the vulnerable and manage new outbreaks. What does this really mean? I know is what you're asking. When are we back to normal? And I think the real answer that most would provide is that there's going to be a gradual resumption of normal activity, and the disruption is likely to continue for 18 months. And lifting these measures early in the absence of the interventions that need to be in place will likely result in new spikes of the virus. I want to speak just very briefly on what this looks like in our region, rural northern New England. I'm going to talk about 4 different pieces of this: populations, health systems and healthcare, response and then the broader impacts of the pandemic. First, when we think about our population, many of us know that many of our rural communities are older than the US population on average, and therefore many of our communities are medically vulnerable in a number of ways to the virus. We know that our region has significant health inequities. On the one hand, we lead the nation in terms of our overall health indicators, and yet we know that we are also at the top nationally in terms of the rise in midlife mortality. We have a significant opioid epidemics. We have quite a bit of underlying social vulnerability. One of the things that's seen as a protective factor for our population, though, is the physical distance that naturally exists within our communities. I would say that that is also a risk factor because we may not see ourselves as vulnerable to the virus's spread, particularly in the early phases. So it's something that we need to be mindful of as we look at how we're going to return to normal. Second, I want to talk a little bit about our health systems and healthcare. We're in a rural region. We have a lot of our population depends on critical access hospitals as well as rural providers that may be small, and already we're facing significant financial challenges prior to the pandemic. We know that this pandemic is already having significant impacts on our health systems and healthcare, and we need to be very mindful about this, not only in the context of the immediate response, but also in the longer recovery period. Third, I just want to talk a little bit about our response. One of the things that I think is very protective of this particular region is the vitality we see within our communities. A lot of communities have mobilized very quickly. We see governments and social service agencies and communities coming together to ensure that those that are most vulnerable in the community are getting support that they need, just to make sure that there are support services in place and to make sure that the public health measures that are being instituted are actually implemented at a community level. Finally, we know that this pandemic is having significant impacts that go far beyond health in our communities. We know that a lot of our businesses have been really affected. We know that a lot of our public institutions are strained, and we're going to have to think about that as we move forward in the response.
So I'll just speak briefly about aspects of how public health is organized in the US, so you have a bigger picture of what's going on. Outside the US, certainly at the global level, this is a global pandemic, and we need partnerships and we need leadership at that level. And at that level is the United Nations organization, the World Health Organization. They have representation in all regions of the world and in many of the other nations of the world. And they're a vital asset to dealing with this. At the federal level, there's this kind of a 20,000-foot view. The federal level has lots of money and lots of scientific and very good management expertise available to it. Some of the major players at the federal level would be the Centers for Disease Control and Prevention, the National Institute for Health, the National Stockpile, the Centers for Medicare and Medicaid Services are a player, and with Homeland Security, although not technically public health, but certainly very closely related, we have the Federal Emergency Management Agency. At the state, the tribal, and the territories, it's about the 10,000-foot view. There is some money, but there's also excellent scientific and management expertise at that level. At the local level, you have the ground level view. There is not a lot of money, but there is very good expertise, both for science and management. There's also the invaluable local knowledge. There's also an incredible variation in the organization of public health at the local level. In some of the small states, like Rhode Island and Delaware, there are no local health departments. The state health department is essentially also the local health department. In many states, other than the small ones, there are various hybrids. In Massachusetts, The state health department has coordinate powers with the local health departments, but each town is expected to have a functioning local health department. So Boston, with a population of somewhere in the vicinity of 700,000 people, and Mount Washington, with a population of perhaps 40 people, are expected to have health departments that provide the same range of services. In Tennessee, most counties or most of the health departments are at the county level. The county health department is also a local health department. But there are also 4 independent health departments there in the large cities: Knoxville, Nashville, Memphis, and Chattanooga. The large cities like New York, Houston, Miami, Los Angeles have health departments of their own, and they are coordinating with the state health department, but they kind of go their own way. This variability in our system, which is why I have it in quotes in the title, is due to history. As each state developed and each state came into the union, they had their own sense of what works for them. And this is kind of the American way. If I could have the next slide, please. So as you can see, the public health, this is a public health centric view of the world. You can see that the public health agency, in order to do its job, really has to have strong connections with a wide variety of organizations that have, they provide different services of a health nature. They serve different populations. They have different agendas. They may speak a different language, and they may have different cultures. And I'm not just speaking about population cultures, but it may be a professional culture. Corrections or law enforcement have different cultures than public health, and we have to recognize that and be able to work with each of those different cultures as well. Next slide, please. So these are the 10 essential services of public health, and actually Anne has mentioned every one of these in her discussion. But there are 2 that deal with assessment, and those are your monitoring health, things like surveillance, case count, risk assessment, who's been exposed, who's not been exposed, and then diagnose and investigate. We need to investigate each case. We need to confirm the diagnosis, and we have to look for contacts so that we know who the exposed people are and what we can do with them. There are policy development functions within public health: inform, educate, and empower. We need to develop and deliver accurate information that communities can use and that communities trust. We need to mobilize community partnerships. We need to identify appropriate spokespeople to present and support the health messages. We need to have business involved, such as we have with the COVID-19, and we have so many businesses reorienting what they do in order to help provide the necessary prevention material that's needed. Developing policies. Everything we've been doing has a policy. It's should we be wearing masks? We have shut down business. We have virtual religious services. At some point, we'll be reconsidering these policies and talk about, well, what do we need to do to reopen, which is, as Anne had talked about. And finally, no, not finally, but we have 4 aspects of the services of public health that deal with assurance. Enforcing laws. One thing that we may not think about, but our food still needs to be safe. We still need to have a vigorous food safety program going on. We need to have adequate housing. I'm sure many of you have seen videos of a gentleman being yanked off of a subway by police because he refused to wear a mask in public. So we need to link to as well as provide care. This is not only making sure that we can provide care without going into a crisis at our hospitals, but also we need to, in many places, we've had to establish field hospitals. We have to assure that adequate supplies are available so that the healthcare workers can do their jobs in a way that they're protected. We have to perhaps work with hospitals. Many hospitals own the practices in their area. And we need to work with them to consider maybe closing down some of those practices and moving those physicians and nurses and other professional staff into the hospital. And we have to assure a competent workforce. We need to assure that volunteers are certified. We have to plan for a surge. And an example of this is Florida is taking a very aggressive position on trying to make sure they have enough people to interview cases and identify contacts. What did they do? They went to 5 of the universities within Florida, and they recruited 100 students and faculty members, public health students and faculty members, to create a surge population of epidemiologists. And this is something that public health has to deal with. And finally, we need to evaluate what we're doing. The actions need to be data-driven, and are they achieving the intended outcome? And if not, why not? What needs to be tweaked, or maybe what needs to be overhauled? And finally, at the center of all this is system management and research. Basically, what can we learn from all of our actions and our policies? So, Anne? So, success is sometimes the greatest danger to public health. Public health relies on magicians and relies on funding. We make problems disappear. And you know, how many people notice that there's no measles? Are there people who notice that there's no polio around? Once the problems disappear, the political will to keep the necessary infrastructure also, unfortunately, often disappears. The New York Times recently published a concise history of public health, and they boiled it down to 3 words: neglect, panic, and repeat. Our great challenge is to make the invisible visible and make people realize, wow, we're not seeing these cases anymore. And finally, unfortunately, in the history of pandemics as well as epidemics, the most common outcome of those events has been amnesia. We quickly forget. And this is something that we can't afford to do. And I'm hoping in whatever way I can work towards this, will be to make sure that we don't forget the lessons of COVID-19, and we actually do incorporate changes in what we do, how we do it, so that we don't suffer the amnesia and the problems of amnesia once again. Thank you.
Great. Anne and Paul, thank you very much. Because you were presenting, I think you probably weren't following all the chat and questions that were coming in. We've received a lot of questions. We've got, you know, all the questions that came in advance. But Paul, I want to start with one because of something you just said on the second to last slide. Some of the questions have multiple parts and things like that, but this one's pretty simple. You actually asked, should we wear masks? So I want to ask you and Anne, should we wear masks? Is that, you know, is there it feels like there's been a change over the last couple of weeks. What we hear from health officials and from government officials, we see folks on camera not wearing masks in public settings. And so I don't, you know, I know that there's lots of contingent answers to this, but if there's a concise guidance on it, it'd be great to hear that from one of you.
Well, since you started with me, I think I've had a change in my approach. I do wear a mask. I think it's the right thing to do. You're showing that you recognize our connections. But I know the science isn't strong with masks, but they will cut down some of the unfortunate the spray that happens when we speak, when we cough, when we sneeze. And actually this morning I just saw a video that was published in the New England Journal of Medicine, which was really quite remarkable. They had a person speaking without a mask, and you see a fair amount of spray coming out, and then they put on the mask, and there's virtually nothing. So I'm a believer. It may not be a huge improvement, but I think anything that we can do to reduce the risk for ourselves and for others is worth doing.
Sure, and I can add a couple of things to that as well. As this pandemic wears on, we're working with better evidence day by day, and the evidence around this has shifted quite a bit. The first thing that where our understanding is changing is on the degree to which this virus is airborne. And there's growing evidence to suggest that it is indeed airborne, and that this isn't a growing risk in terms of transmission. We also know that the countries that have been most effective in stemming its spread have instituted policies requiring masks. So while it doesn't confer complete protection, I think it is one component, of our public health strategy. That said, there is something that I want to add, which is that we, the public, should not be wearing medical masks. We have critical PPE shortages, both in the US and in other settings. And so we need to ensure that all of the medical masks that we have are reserved for our health workforce on the front lines.
Great, that's really helpful, thank you. And you, just related to spread, one of the slides you put up indicated that 14 days of quarantine might not be adequate. You noted sort of asymptomatic transmission that might happen for 3 days beyond that. So there was a question when that slide came up about why are we getting direction for 14 days of quarantine? Because it looked like you had sort of a 17 to 20 day window. So there was just a little confusion about that.
So the 14 days is the incubation period. So the time from which someone is exposed to the virus to the point at which they might develop an infection. And some of those infections are going to be asymptomatic, and some people who are infected will be able to spread the virus for 2 to 3 days before the onset of symptoms. So once someone has passed that 14-day window, we think that they can't be infected beyond that point. But the real challenge is that we really have very limited testing, so we don't know who is infected and who can transmit the virus and who is not infected.
Yeah, we had a question. Oh, go ahead.
And most people are, we think that the median incubation period is about 5.4 days. So most people are developing, most people who are going to be infected will be, they will have illness or they will be infected before that 14-day period has passed.
Yep. We had a question, because you just mentioned testing, let me just jump to this question. We had a question related to testing that, let me just grab it here. I can't find where it is, but it was basically, how do we know if the number of cases is actually growing, if at the same time we're doing more testing, so we're discovering these cases that already exist? Is there any science behind the projections, or is it just that we're testing more so we're more aware? I mean, that's not exactly what the question was, but there were 3 or 4 people had asked about that earlier. So
the more testing we do, the more cases that we're going to find. But also the more cases that we find, the more our case fatality rate is going to go down, because we're going to have a better denominator for the overall number of cases. The problem right now is that we are limiting testing because we have, there's a limit in terms of the availability of diagnostics and laboratories to process those tests. Second, we have critical shortages of, as I mentioned earlier, of PPE for healthcare workers that are providing those tests. And then we also have challenges around our health workforce. But we do need, one of the things that we absolutely need to do is expand testing. We're not going to be able to get out of our current, this current situation until we have both regular testing for people who are currently infected with the virus, as well as those who've recovered. And that type of testing is done serologically or through blood testing.
So, Paul, go ahead, Paul.
Yeah, I think this is a common problem in any setting. Is the increase in numbers due to testing, or is it is it increased testing, or is it increased transmission? And I think be wary of anyone who says it's one or the other. There are nuances, there are shades of gray, and unfortunately, this is one of those shades of gray. And so, if you're seeing, oh my gosh, the numbers are increasing, the numbers of cases are increasing, you have to understand that there may be more than one reason for that, and that it takes time to really have a better sense of what you're looking at.
So Paul, we had so many questions beforehand and during the session about opening, about reopening of society, whatever that might mean. So sure. I guess, Paul, to start with you, what data, just at its most basic level, because this relates to the testing, I think, what data do we need to even develop a strategy to reopen? What folks who we see on TV, folks at the CDC, what do they need for data to begin to project and say, oh, this is the timeline?
Well, I think that we need data that we don't really have in good quality right now. And Anne just touched on it. It's so dependent on the testing and the ability to test extensively. And when we have those, when we have the supplies, when we have the actual testing in practice, so we can identify those different classes of people, who's had this, who is presumably immune, who is susceptible, who is probably infected right now, and who are their contacts. I think at that point we're in a better position to be able to answer the questions about reopening and what that reopening will look like.
And I think you might have a follow-up, but let me add to that question. We had a question during the session, and I think, again, it relates to the testing and some of the conversations we're hearing. So I'm just going to read it. The Sunday Boston Globe, there was a Sunday Boston Globe article that indicated that social distancing just postpones the inevitable, and that without a vaccine, herd immunity is likely the way to end this pandemic. So again, we've got sort of limited data. We don't yet have a vaccine. Testing is in the background here. Do you have a reaction to the herd immunity conversation that we've had, where people are saying there's no vaccine? What's the way to get to that next step?
Well, I think what we want to do in order to achieve herd immunity, or what we don't want to do, is to overwhelm our medical care system. And then you've got great risk, not only to the healthcare workers, but you've got great risk to the people who are coming in for care. And you come into some of these scenarios that we don't really want to deal with, where you try to decide, like the Italians professional society came out with their guidelines as to basically who do we treat and who do we have to leave alone, because it quote unquote, it's not worth it. I mean, how do we say that about anybody's life? So I think that, if they want to roll the dice and accept the number of deaths that CDC had originally forecasted or predicted, that's one answer, but that's not, I don't think that's a public health ethic. So I think we have to make do with the non-pharmaceutical interventions. It's going to prolong the pandemic, but it'll also allow us to manage it.
Anne, do you want to add anything to that?
Sure. So I talked a little bit about what it means to flatten the curve, and flattening the curve simply means that we're bringing, levels of transmission down to the point that our health system can respond to those critical and severe cases that are coming in. And so we're going to need, to continue with some of these measures to ensure that case levels don't increase beyond that point. Lifting the measures right now without any of the things that we need in place will just about guarantee that we are delaying, another spike in infections, and if not, several spikes in infections. And so there are a number of pieces that have to be in place to do that. The second thing with regard to herd immunity is I think that we really need to deconstruct what this means and what we're talking about, in terms of our society. We know that mortality is highest in certain groups. We know that older people have much higher rates of mortality. We know that people with underlying illness experience much higher rates of mortality. And we also understand that it's not distributed equally across our population. We're seeing, incredible inequities in terms of the outcomes of African Americans, of our Latino community. And we really need to think about whether we are prepared to accept, that there are parts of our population that will be much more vulnerable if we just lift measures without adequate protections in place. So I think the costs of strategy that's built around a mortality will be really significant from a societal perspective, and that those costs will not be equitably distributed.
Thank you. Really helpful. Can I, a couple of questions that we received beforehand about just the ways things are spread. So you talked a little bit about this when we talked about masks. During the session today, we had a question. Let me just get back to it. So this relates a little bit to where we live. One question was, can you speak to any known risk, airborne risk of being outdoors on kind of small town streets, dirt roads, the places we all live around here with no people present at the moment, but somebody might have been there before. And that links to a whole series of questions that the three of us reviewed before we did this that we received about just, is it spread like TB or measles? Is it an aerosol spread? How long does it remain someplace? I think the no people present in a small town question gets to that. If I come back to my office for the first time in 3 weeks, as I did today, and somebody was here 5 days ago, is there some concern? Is there good science around that, Anne?
Yeah, so I think our concerns around airborne transmission are most significant in our healthcare settings, where there are decisions that are being made around what healthcare workers should have what level of protection, especially given shortages of PPE. Should our healthcare workers have N95 masks, or should they have regular surgical masks? This is where we're going to see the most airborne transmission taking place. And our concerns go really beyond the COVID-19 treatment areas to the whole health system, because we know that some of the most explosive, cases have occurred outside of the COVID-19 unit. So we have a patient that comes in to obstetrics to deliver a baby, and 2 days later, spikes a fever and is determined to have COVID-19. Out of the clinical setting, though, I think in a rural region, the risks are really minimal. I think it's fine for you to walk outside. If you're going to be walking outside, with friends or with neighbors, you want to maintain that 6 feet distance. If you're out in community, you want to have a mask on, but you should not. I would caution against interpreting the data around airborne transmission as needing to limit outside activity.
Paul, how about, I don't know if you've read much about I'm sure you have, the articles we see about it living on, plastic and steel for 3 days, or if something's delivered to your house from Amazon, that it might live on cardboard. If you go to the grocery store, is there a sort of accepted accepted practice and science about the surface sort of life of something like this, Paul?
I know that, yeah, there is some science in terms of the viability on different surfaces. And so we try to clean those. I know a lot of people have, if they get a package, they let it sit there for a couple of days. Maybe they'll take it into the house. Some people are, when they collect their mail, will do the same. They won't open it for a couple of days. This is all, I think, I mean, in my mind, maybe I'm a little lax on this, but I think it's there are many things that are possible, and you have to think about what's probable. So I have no objection or no would not want anybody to think that they're doing something silly by not opening things immediately. I mean, if you want to, you can always take a wipe on the box and then open it up and then get rid of the box as swiftly as possible. And just going back to Anne's comments, I agree wholeheartedly. If you're going outside, I mean, there is, and I'm not sure that we know what the infective dose actually is, but think of the amount of dilution happening just by walking outside. So enjoy your walks. The walks are important. The runs are important. The hikes are important for your health for many reasons.
Just in terms of the data and surface contamination, first of all, most transmission is not it's not happening through contaminated boxes or food objects. It's person-to-person transmission. And so that's where our interventions need to be focused. But we do have data suggesting that the virus can live for a very long time on surfaces. I think the best data we have comes from the Diamond Princess cruise ship, where there was virus, live virus found 17 days after the ship was disembarked. Whether or not transmission is possible at that point is not yet clear, but we do know that decontamination will need to happen for a long time after. That said, it's really human behavior that needs to be modified versus objects like mail, and clothing.
Great. So we're getting very close to 1 o'clock. I want to thank everybody who's attended. I'm going to 2 more questions. One I think is very quick. Anne, can you remind people what COVID stands for? Because 2 different people asked that question, and I couldn't answer it because I couldn't remember the exact acronym.
So we're using COVID-19 is the illness that is caused by SARS-CoV-2. and that SARS-CoV-2 is a serious acute respiratory syndrome, coronavirus 2. There's SARS-1 that we had earlier, and so it is when we talk about COVID, we are talking about the illness.
Okay, great, thank you. And then I guess as a closing, we don't have a lot of time, and we're going to lose people as we go along here. We've talked a lot about reopening. We had a bunch of questions related to it, and one that came up during the session that was related to another one that had been submitted earlier was that government leaders have discussed social distancing in some form or another, lasting into 2021. The question that came up during the chat was that somebody yesterday referenced going out to 2022. I'll let Anne go first, and then Paul, do you have a sense of what that might look like 3 months from now when we're talking about physical distancing, but we might be going to work, what it might mean for schools, for colleges, for events? I don't know. And that maybe it's too long an answer to get in the next 5 minutes, but let's try.
So the best data best data and analysis that we have comes from the Imperial College of London, I think, and they projected that we're going to need to have measures in place for about 18 months. or at which point that vaccine is available. So even though, you know, we are talking about reopening does not mean a resumption of life the way it was pre-pandemic. We can expect to have different layers of social distancing measures in place for a while. And that will probably mean that we are not all returning to work in the same form, that schools could be looking at decisions to be online. Further into the future, you know, a lot of the, we saw cruise ships, being places where there was quite a bit of transmission happening. Colleges look a lot like cruise ships, and so there will be decisions that will have to be made around our academic institutions, and both at higher education as well as, our primary and secondary schools. So we can expect disruptions for a long time moving forward.
Paul, anything to add to that?
I can just say that reopening does not mean that we can party like it's 2018.
Yes.
Thank you both. Kristen just put in a question to ask about if this information will be available in the future, and it will. We have recorded this session, and we will share it through an email in the next few days, and a link to a YouTube video. So we will get that out there. Next week, I put this in the chat, but next week on April 23rd, we'll do our next Colby-Sawyer online conversation, and that will be a town hall with President Sue Stubner. So many of you asked questions about the factors that Colby-Sawyer will consider before we reopen, and what that might look like. And we're all wrestling with that. I can't promise you that we'll have answers to those questions on April 23rd, but we'll tell you what we're thinking about and the kinds of decisions that we're making, and so what we're projecting and looking towards. So next week we'll have a conversation about that. I want to thank all of you for joining us. We had about 110 people at our peak attendance in the middle of this, so that was great. And I really want to thank Paul and Anne. It was incredibly helpful. I received a lot of messages from people who said they just really appreciated the perspective. So thank you very much for doing this and sharing your knowledge with us. We really appreciate it. And thanks for joining us. I hope you can join us next April 23rd, next Thursday. If you received an invitation to this session by email, you'll receive an invitation to that session by email as well. I hope that you're all staying safe and healthy. And thanks again for joining us. Look forward to seeing you next week. Take care.